about MOLST, which I'm just going to leave it there because that is not my area of expertise. I think Dr. Moss, you probably can speak to it much better than I can, if you want to, just so Senator Anwar understands where we're at today.
Sure. So nice to see everyone. Happy Wednesday afternoon. I'm looking out at some fall leaves, and it's just, how did we get here so quick? But it's a beautiful afternoon. Crisp, cool afternoon. So I have over time worked with Barbara Kess and others on the MOLST concept here in Connecticut. It was part of that committee when I very first was a baby attending here, and we have worked on it. And then I had not been so involved for some time, but MOLST is really now, it is what MOLST stands for, as most of you know, is Medical Orders for Life-Sustaining Treatment. And it's really changed what our paperwork and our information is that we provide families and patients when they have chosen to protect themselves or their loved ones from suffering. And so Connecticut has worked really hard to develop a beautiful MOST that is being used streamlined throughout medical organizations, and we are now utilizing it in pediatrics. And so I really wanted Barbara to bring all the work that she's done for years on this, and she really has led this effort here in the state, and bring it to all of us to understand how it impacts pediatrics and what it can look like for pediatrics, and just so there's an awareness of the tools that we're using currently. So that was the idea behind having her speak today, is I think the work that she's done and the utilization of this document can be a really important component of the care that we provide these children at home at the end of life.
Yeah, and I'm oh no, it's just the 11. 1, 2, 3, 4, 5, 6, 7, 8. Okay, so we're still waiting for her. I think also we can go over what the action committee has been working on, which has been mostly looking at other states and how they are doing pediatric palliative care and pediatric hospice. Also looking at how other states have done changes to some bills and how that has helped them take care of more children. Also incentivizing nurses to even do a rotation into pediatric hospice. So we're working on coming from a bunch of different angles to try and put something together, obviously for February, that will show all the things we feel need to be changed, amended, or looked at further in order to be able to take care of more kids in the state of Connecticut. We have Iowa doing some cool things, Minnesota, obviously Massachusetts. And I think the good part of it, and, you know, Senator Anwar, for you to know, is except for Massachusetts, the other states that are taking care of a lot of kids on palliative or hospice care are not doing it through a state-run program. They're doing it by building good regulations, by changing some bills, some things about what exactly defines pediatric hospice, and how they have changed it in, I can't remember if it's Iowa or Minnesota yet, but is that they define a child who can be coming onto hospice as a child who's medically complex. Jessica, keep me honest here if you remember, but a child that can have medical complexities or be medically fragile that we know will not live to adulthood. So that's everybody from 21 and younger, and I think Minnesota might be 26 and younger. And they're saying that really we should be looking at it from a perspective of, we know that they are terminally ill or medically fragile, but we cannot gauge the time of death because of concurrent care. So we should be able to treat them because we know they will not live to be adults. So a lot of different things that we're learning about and putting together. And Jessica, I don't know if you have anything else to throw in. Jessica and I did a call with Jonathan Cotter yesterday or the day before. Tracy, you may know Jonathan Cotter. I'm not sure. Okay, he runs what's called Ryan's House. It's in Arizona. It is a respite home for kids, but he also runs like a national coalition. Where's Eileen? Eileen probably knows him also, and Elle. I know because he actually mentioned you, Elle. And they're looking into making a lot of changes, and he's very in tune to how they've done things in Iowa and Minnesota, and Connecticut can be a little bit different. I think he has a vast amount of knowledge for respite, and how that can work in from a palliative care perspective and things, but from hospice, it's a little bit different. So I don't know, Jessica, if you have any other comments, because I still don't see Barbara.
Yeah, I think you did a great summary, really just focusing on the palliative definition of how they care for kids with medical complexities and how the respite homes fit within that model of care. But the recognition that that is an aspect of a lot of the bills and legislation that they've been working on with those states, rather than the full encompassing foundation of really defining what hospice, palliative, concurrent care, and putting in those protections. But I thought that it was a great conversation to hear some of that language and how they've been able to work with experts in different fields to be able to lobby and educate on those things. And also just that passion of being able to provide a safe option for these kids that are navigating these illnesses, and hopefully partnering with hospices to help provide care in the respite facilities as well.
Right. Right. Hi, Representative McCarthy Vahey. We were just going over some updates as a whole group today.
Hi, Tony Ann, and hi to everyone. Forgive me for being off camera for now, but it's nice to see everyone.
Absolutely. We're grateful for your time. And also what we plan on showing in our report out is, you know, we have about 250 kids on the Katie Beckett waiver, which means that they are provided with Husky, even though they don't meet the financial criteria to be on Husky. But we also have 300 kids on a wait list for Husky. And also we have heard from some parents, one especially whose child is still alive, that waited 5 years to get Katie Beckett and has been a 24-hour-a-day caregiver for her daughter in the home. And how can we help there and show that if they're able to get on Husky and be on palliative or hospice and still get their shift nursing through the concurrent care, we also need a lot of shift nurses to be able to do that. But we then can reduce the cost of them going into the hospital. So it's much more expensive with a hospital stay than it is if they were on palliative care or hospice through Medicaid and Husky. So lots of things we're excited to show you by February, lots of things that we're working on. And it really is an honor to do this work. So thank you both. And I'm so glad that you both are on. And I see Barbara, the woman of the hour, has joined. So Barb, if you want to do an introduction about yourself, and then if you could just go on into MOLST, that would be great.
Perfect. So good afternoon, everyone. Sorry I was late. I had to reboot my computer. My name is Barbara Cass. I am the Senior Advisor to the Commissioner of DPH for Long-Term Care. However, prior to that job, I was the Branch Chief in Healthcare Quality and Safety. I have been at DPH for 25 years, and for the bulk of my career, worked in the regulatory area. But because I'm an old nurse, I did work for 15 years on the clinical side as well. So it's a privilege for me to be part of this work group. Tony Ann and Dr. Moss are incredible co-chairs, so thank you for your work on this. And I'm just going to go right into MOLST, which is one of the work groups that I am working on and facilitating. Again, several of the members of the MOLST are also members of this pediatric hospice work group, and there is lots of intersection between pediatric hospice, pediatric palliative care, and MOLST. And I can share my screen and work through the slides, or Peter, I'm not sure if you could help with that. There's a little bit of a joke at DPH that I have not gone to PowerPoint school yet. And they're going to send me so that I learn how to navigate in a Teams or a Zoom call. I'm happy to try to do it.
I can share.
Peter, you're an
Yeah, I
expert.
can share. Yeah.
Okay. I'm going to look to my MOLST colleagues. If there's anything that you would like to add, please just feel free to add. Several of the people that are on the MOLST advisory group that are working in pediatric hospice have been there from the very beginning. So they have much more bench experience than me. Okay. So Peter, we could go on to the next slide. Thank you so much. So where did it all start? This has really been a work in progress. And in 2014, the enabling legislation was passed to start the MOLST pilot. But it started many years even before that. The work group had convened to assemble the policies and procedures, start the legislative process. What did MOLST look like, and who was MOLST for? There was a pilot that was focused on one hospital in Connecticut, and there were 100 plus MOLST individuals or Connecticut healthcare beneficiaries who had executed a MOLST with their eligible provider. The MOLST pilot transitioned into Public Act 17-70, which was the authorizing MOLST statewide. I've included some hyperlinks on the slide, and I think we can share the slides at the end of this with anyone who would like to actually see the actual statute, the actual policies and procedures, and the frequently asked questions. As part of the enabling legislation, a MOLST advisory council was established, and this is a group of upwards of 15 to 17 individuals who are very committed to this project. It is an interdisciplinary group. We have advocates, we have healthcare providers, we have individuals from the emergency medical services community, we have representatives from CHA, the Nursing Home Trade Association. So this really has taken a village to get this work done. Peter, if you could just pass to the next slide, I'd appreciate it. Thank you. So what is MOLST? MOLST is a medical order for life-sustaining treatment. We use the acronym MOLST, and it starts with a conversation, and it represents an individual's decisions about their treatment preferences at the end of their life. It directs a patient's right to accept or refuse care. Who is eligible? So we have really tried to underscore in the work, and most importantly in the recent work, that it's for patients of all ages. And while we never like to contemplate or think about young people at the end of their life, it is for young people as well. And there are two eligibility requirements. It's for individuals who are at the end stage of a serious life-limiting illness or a patient in a condition of advanced chronic progressive frailty. Who is it not for? In Connecticut, it's not for every single individual who enters a nursing home or every individual who's receiving supportive services in the community. It's for an individual who has had a conversation with an eligible provider, and the eligible provider is defined as a physician, an advanced practice registered nurse, and or a physician assistant who has taken the training. And we do have a training program that's been established. It's posted on CT Train, and it can take anywhere between 30 to 45 minutes. And a certificate of completion is provided at the end of the training. And that is the first step in the conversation with a patient. And the patient, first and foremost, is the one making the decision about what their preferences are. If the patient is incapable of making healthcare decisions, the law does contemplate who can do that decision making. And it is the parent of a minor child, a guardian appointed by the probate court, a healthcare representative, and again, the Connecticut General Statutes define healthcare representative, and the appointment of a patient's healthcare representative must meet the requirements in the statute. Peter, next slide, please. I just added this slide for everyone to have. This is how it is defined in the statute. And here's legally authorized representative, a minor patient's parent, guardian appointed by the probate court, or a healthcare representative. We often will get emails regarding MOLST forms from healthcare providers who are interested in starting the conversation with their patients. But we always do check to make sure that the eligible provider has taken the training in CT Train. And we can check that in the background, and it also is just the provider confirming that indeed they have taken the training. And we've had conversations as a group. Not every state provides or mandates that the training is required. We've had conversations through the advisory council that, well, why do we want training? We feel as an advisory council that the training is critically important. It's a conversation that's thoughtful, a conversation that's deliberate, and the training does talk about how to start the conversation with the patient. So obviously the conversation is very important to us. Peter, next slide, please. And here are the Connecticut General Statutes that just restate the conversations that I have, the appointment of a healthcare representative. Next slide, please. So the national perspective. All 50 states have some version of MOLST. Other state references include POLST, which means portable, or in some states it's physician orders for life-sustaining treatment. Other states may use the acronym COLST. POST. POLST was the first, it's the National Association for Orders for Life-Sustaining Treatment. And there is a national effort being done, bringing in all of the states with their version of orders for life-sustaining treatment. They have a national form, and many states have adopted the national POLST form. Connecticut and other states have retained their own state-specific form. And one thing that I always like to underscore when I have the opportunity to talk about MOLST is that MOLST is just an element of advanced care planning. MOLST is very distinct and discrete in that it's a distinct medical order that's portable. It's portable throughout Connecticut, across the healthcare sector. It's used, I did mention that it's not for every individual in a nursing home, but there are individuals who are eligible in nursing homes with a MOLST or in the community. And I've always said that the first knock at the healthcare door is EMS. And we have done lots of work with EMS. As I mentioned, EMS is on our advisory council. So they provide great information as we move forward with decision making. Next slide, please, Peter. So what is the difference between MOLST and a living will? This question does come up often. And as I mentioned, there are two criterion for a MOLST, and it is related to health status: end stage serious life-limiting illness, or an advanced chronic progressive disease with accompanying medical frailty. We hope that it's always a thoughtful and comprehensive conversation between the patient and or their legally authorized representative. The conversation can take a couple of visits. It's not just in some cases, a one and done. The very distinct difference between MOLST and the living will is it is a medical order that has portability. So individuals living in the home who may have a call to 911, they will provide evidence to their EMS responders that I do have a MOLST, and that's incredibly helpful. And again, incredibly helpful for the next stages of that EMS call. There is no age requirement. It's for the young child up to the very frail elderly person. And currently, there are signatures that are required. The eligible healthcare provider, the patient, and or the legally authorized representative is required to sign it. The current form does require a witness signature. Excuse me, but last session, there was a legislative proposal that was passed that eliminated the witness signature. However, I do have to there is a caveat. We have not formally released the new form yet, and I'll get to that on the next couple of slides. And then I do have some bullets about the living will and what does a living will mean. And it lists preferences for aspects of healthcare, but it does not require a discussion. And I want to really reinforce that it is not a medical order. So that is the distinct difference between a living will and a MOLST. Living will, anyone greater than 18 years of age. So it is not for all patients. And it does require a declarant's signature and 2 witnesses. Next slide, please, Peter. So operationalizing Connecticut MOLST, it is voluntary. It is not a requirement. And again, that's where the conversation is so critical. It's transferable or portable among all healthcare institutions in Connecticut, and it may be honored in other states, but not all states. It does provide evidence of a patient's preferences. So still a very valuable tool out of state. Current form is a line green form. And the policies and procedures, interestingly enough, are very specific. And it does, as I've indicated in the bullet, while at home, the eligible patient shall keep the MOLST on the refrigerator. For individuals that are in a group setting, such as a nursing home or a group home, we are suggesting that they keep it on the back of their bedroom door. It also, a copy is kept typically in the individual's medical record. Requires a witness signature today, but the policies have been revised. The training requirements, I did talk a little bit about that. And the group has had lots of discussion about it, and we continue to believe that the training is critical. There are instructions on the form, and all of the instructions must be followed. And I've also added as a last bullet that we're doing a lot of work with socializing MOLST and messaging MOLST. So we have identified that the request for forms has doubled from 2023 to 2024. We are out doing a presentation whenever we have the opportunity. A few weeks ago, I was at a managed residential community down in the Mystic area and spoke to 100 people about MOLST. So there is lots of interest about MOLST. Peter, next slide, please. And this is what the form looks like. Again, it is lime green. And the challenge for me right now is having this discussion about what the form looks like now. It's important for me to note that the form has been completely revised, but this is our current operating tool, and the spirit and the concept of the MOLST form is still the same. But in the hopefully the very near future, you will see that it's no longer, and Peter, if you could change the next slide, you'll see the back of the form. And it does have section D, does have a section that identifies if there have been frequent conversations and who the form has been discussed with. And next slide, Peter. And this is the third side, which again shows how many times the discussion has been reviewed with the patient. And one more slide, please, Peter. Oh, that's it. So we have taken 3 sides of a MOLST form, and now it's a double-sided MOLST form. So next steps. We have been working in the last 18 to 24 months on modernizing the process. The early pioneers of MOLST did all the heavy work. They pursued the legislation. They oversaw the pilot. They did after action reports about what worked, what didn't work, and now it's the responsibility of the advisory council to modernize it. And what have we done to modernize the form? We have eliminated the witness signature. We are revising the policies and procedures. And the policies and procedures, the high-level concept behind the policies and procedures is the elimination of the lime green form. We are working very hard to do a digital-first approach so that an eligible provider can go into our website and just print off the form. It will be a PDF fillable form. This is what we envision, a PDF fillable form that the eligible provider can complete and print off and give to the patient. We have spoke extensively in the new policies and procedures about a process to revoke or amend a MOLST form when there are changes. A patient may indicate at one point in their MOLST journey that they want one treatment preference, but people change, lives change, conditions change, and they may change their mind. And we wanted to identify a very clear pathway to how that would happen. And we've done lots of good work, I think, on our training expansion. And in so much, I'm looking at Dr. Moss, and in our new training, Dr. Moss helped us with a pediatric slide. It was important to the group that we have representation across the whole age continuum with MOLST, identifying that it is not just for frail elderly individuals. MOLST should be an access tool, a preference tool for all people. And we are also looking to clarify the definition of an eligible patient, and I won't get into the nitty-gritty of this, but we want to clarify an eligible patient with the inclusion of a physician's assistant. So next slide, Peter. I think that may be the end. Yep. These are just some resources that I've added, and then I will look to my colleagues on the MOLST Advisory Council if there's anything that I have forgotten. I didn't want to spend too much time, take up the whole hour. But have I missed anything? Tony Ann, Dr. Moss, Tracy?
I don't think
Thank
so,
you.
but I'm not an expert.
Yeah, no, I think you've hit all the key points, Barb. Thank you.
Agreed.
So hopefully, I am hopeful that in the spring of next year, we will be fully operationalized with our modernization. Melia Allen, who provides a lot of administrative support to our group, is currently working on the training. And we want to include many of our advisory council members in the training. They've done incredible work. Their passion is so clear on this. So you will see them if you ever take the training, doing the training. So thank you. So
I have a
Tony Ann, if there are any
question.
questions.
Yeah, so I just wrote down a couple because like I said, I've heard a lot about it. I don't know a lot about it. But when you say like, is this active today? Like
Yes.
okay, so it's active
Yes.
today. And I was just wondering, so when it says eligible diagnosis, if you don't have an eligible diagnosis, then this is something where you would just stay with your regular like living will or something like that until you have a diagnosis, or am I misunderstanding eligibility?
That's part of the conversation between the eligible provider and the patient. Together, they're going to determine the eligible criteria. I don't think we can paint with a broad brush what advanced progressive frailty means. I think it's person-centered, and that's why the conversation between, again, the provider and the patient is so critical to this process. We have had conversations with advocates who have indicated that there were concerns that individuals living with a physical disability who may have a diagnosis of spina bifida and have medical nutrition might be put into this cohort where they're living their best life. And they would not even be a candidate for a MOLST. So in the early days, there were lots of concerns as to how this would impact the community of individuals living with physical disability. So there's been a lot of discussion around that.
Okay, thanks, Barb. Does anybody else
Thank
have
you,
any
Tony Ann.
questions?
It's
Go ahead.
Stephanie Massaro. Sorry. I just wanted to say that as someone who provides support for families who are thinking about outlining their goals of care in a more definitive way, transitioning their care to somewhere other than the tertiary care center, home, for example, the diagnoses that render you eligible are in fact, quite non-binary. They're not discrete. And I do think that anyone who wants to talk about how they want their care to go is potentially eligible. So like we have children who transition to home and their quality of life is best sustained by doing age-appropriate things like attending school. But the family is very clear that they have a declining physical state, that interventions that have been proposed are not in keeping with their goals of care. And so they use this as a way to make sure they can communicate with anyone who may come to care for them. And so we put the MOLST in a, plastic sheet and make sure it's with the patient in their medical binder when they are off doing some of these activities where they may be separate from their parent or their guardian and decision maker. So I just want to be mindful of the fact that I think it's a little subjective in terms of eligibility criteria because we want to support families in their voice, and this is a tool to do such.
And I think that's where, again, and I hate to keep reinforcing it, but that's where the conversation is so critical to this between the provider and the patient or the patient's family.
Right. Thanks, Dr. Massaro. I see Representative McCarthy Vahey with her hand up.
Thank you, Tony Ann. And I don't know if it's okay to stop the sharing. Barbara, are you okay if we?
Oh, yeah,
Peter,
I'm fine.
okay. That way
Thank
we
you.
can see each other a little bit better. Peter, thank you for that. So I'm thinking about changes and actually was thinking about the refrigerator piece for the form. And then it said they're going digital first. And thinking a lot of people don't have magnetic refrigerators anymore. So I know that sounds really silly, but when it comes to those moments at the very end of life, if there is a question or a crisis time, unless you know exactly where things are, which is why I understand why it would say refrigerator or bedroom door, because then everyone knows it's a very set thing. In a digital first environment, is the expectation then that there would be a printed document that would then be placed somewhere? I'm just curious about the mechanics of that and how that works, because so many of us now, we are using our phones. So will there be an option? Say I'm a family member and I'm caring for my family member. Will I be able to show something on a phone? Will it have to be posted? Just what those conversations are like. May seem really nitty gritty, but I'm just thinking about those end moments.
So we've had conversations, discussions about exactly those issues. And again, in 2014, it seemed relevant and applicable to put in the policies and procedures, put it on your refrigerator. We've had lots of conversations about, we live in an electronic age. We've had conversations that have included, and I'm saying this with some trepidation, but an e-MOLST registry, so that when a eligible provider has the conversation with their patient, they upload it into a registry. Massachusetts is starting an e-MOLST registry. Oregon has had one for several years. So we're starting to look at those options. Look at them carefully, though, because they often, as everyone on this call knows, have money attached to them. Where do we get the money? But with the providers on our advisory council, they have suggested, and this just makes great sense, when they're doing the MOLST conversation, developing a tab in the individual's clinical record, that it's automatically uploaded, and again, it's only as good as the patient continues to communicate with their provider, because it is voluntary and it can be changed at any moment. So we've had lots of discussions about, as we modernize, how do we get there? So thank you, Representative McCarthy-Vahey.
Well, I thank you, Barbara, for all your work on this and so many other things. You know, I think about this in a lot of ways, just alternating caregivers, if there's a registry. I mean, it's really complicated. So I appreciate the fact that you're having all of these different conversations, including, you know, certainly the cost, but also the difficulty of keeping digital records up to date. And how that mechanism for making the changes then happens, you know, with the digital record too. It's fascinating to think about, and I'm grateful that you're all doing that.
Thank you.
Jessica.
Yeah, I just appreciate so much this education and that recognition of the importance of the conversation, because things do change so quickly. Families will often change their mind, and just maybe a point of clarification, or just for my own awareness of how this is approached in the Connecticut space, but in other states and other organizations, the typical approach is also when a advanced care directive like a MOST or a POST or a MOLST, all the different acronyms, when they are completed and reviewed with the family, oftentimes the family is given that as a gift of choice in a moment, understanding that when their child is going through an maybe acute change in condition or an unexpected change in condition, that they may change their wishes in that moment. And they may want to pursue all possible interventions to sustain life, despite having a MOLST in place that indicates no CPR or no intubation. And so typically from like the clinical space and working in home hospice for pediatrics, we've really approached that with families to say that this is what gives you that choice in that moment. Because if we don't have those advanced care directives in place, there is that legal obligation from a medical side that 911 is called, and EMS does do everything to sustain life, which also goes back to that point of where this is located, right? And knowing where that is so that you can procure it when you need to. So I think my point of clarification here is also when we think of a digital registry, when we think about sharing this amongst other providers, is also how families are communicated with in the space of the flexibility of this document, and knowing that they can always do more, but in the moment you cannot always do less. And so how we weigh that with families when they're in the home environment. And then just my other quick point is that we'll actually tell families to put it in the freezer so that they don't have to look at it every day and be reminded of it. But the freezer is definitely a place they'll remember in the moment that their form is, because you don't keep other forms in the freezer typically. So we'll tell them put it in a plastic bag and put it in your freezer, then you'll know where it is. And it's in a central part of the home typically. But also, of course, communicating with the private duty nursing agencies, any of their other care team members, so that they're aware of what's on file and what's there.
Thank you, Jessica. And to your first point, the second point, freezer's an interesting place. First point, though, about changing their mind. And we are spending some time in the training about that. And again, underscoring that this is voluntary and it can be revoked, changed, suspended at any time. And that's why we thought it was critical in the policies and procedures to call that out. And this is the process for suspension, revocation, changing your mind, whatever the moment is directing. So we've had those conversations. I actually had a conversation with our EMS medical director this week. We are participating in a New England MOLST COAST committee to talk about portability across state borders. And one of the conversations that came up is EMS trained well enough? Do they clearly understand that it's not written in stone and forever? And I spoke to our EMS director this week, who is actually part of our advisory council, and he indicated that he doesn't have an awareness that they don't, or that there's a knowledge gap there. But we're going to talk about it more, and it is in the EMS protocols. So Connecticut does have an EMS protocol that does address MOLST. So we've tried to put it everywhere we could.
Yeah. It's a difficult process with many moving parts.
Yes.
Just a quick follow-up question for clarification, and this is maybe more of a legal question, but if a family weren't to have a MOLST in place, maybe they just weren't really ready to move forward. There may have been conversations, but nothing was formalized. Is there a legal obligation that they would then, no matter if they're on service with a hospice organization or not, is there a legal obligation that they have to call 911?
I don't know the answer to that. I'm going to look to Tracy, who is our home health care expert, and Jessica, I will get back to you on that.
Yeah, I don't feel comfortable answering that without us really discussing it, but I think that
great question.
if the MOLST is in place and it's clearly outlined, it should be honored. If it's
Right.
not available and the family steps in, it's kind of like the advanced directives. If not available, they go to the family. That's my initial thought about it.
Jessica, we go so far with the home care kids that we care for that we are part of that communication. So I have historically been part of the ambulance coming for support or for transfer options, and then speaking to the ambulance to state these are the family's wishes. So I've done that on many an occasion with a family where they do both, right? So the family's not left in the lurch alone. But if there hasn't been a decision, we often talk about like plans for nurse pronouncement, which gives us an option of who would come in your home and pronounce your child so they don't have to be removed from the home. And that's part of how this whole committee became, is really honoring that opportunity for families. But in terms of whether it's elite, there has to be some plan for us managing the kids. We have to have some plan in place of how we would handle an acute event. And oftentimes we'll have EMS transport them to the hospital for support purposes. Like they will not resuscitate, but bring the child to us so we can then help the family in that moment. And we've done that on many an occasion with the family. So EMS is always very reasonable if you're available to have the conversation with them.
Yeah, absolutely. I realize I opened a little bit of a can of worms, so I'm sorry about that question. But that is something that we've navigated, in the home hospice realm of having a child unexpectedly die during nap time and the family not being able to rouse them. Do they call hospice or do they call 911? A MOLST isn't in place. So how do we proceed from there with a minor child? It's a lot of complicated questions with pediatrics, as always. I just thought I would ask since I had experts here. Thank you all.
Absolutely. Good,
Jessica-
really good question.
And we do have an FAQ document that we're developing and again updating it. So I can talk to our advisory council to see if that's a question, a structured somehow that we may want to include in there. We're trying to anticipate questions that we've actually developed 3 different sets of questions. We have eligible providers, healthcare professionals, and consumers. So we know that there are 3 different target audiences, and we want this to be as helpful to the consumer as possible. So I will talk to the group about that.
Okay, thanks, Barb. And I see
you.
Carolyn's hand is up. You're muted. You're muted, Carolyn.
Muted, right? Can you
There
hear
you
me?
go. Yes.
Okay.
We can hear you,
So-
Carolyn.
I'm the parent that I'm the parent that had to go through all this that you're talking about. I think that your idea is great, and this is what I think as a parent. I think that all the pediatricians or someone who's knows all about it needs to talk to the families and let them know about it, and they need to make sure that they understand what it is, and that they understand what it is, that they change their mind, and then it makes it easier that if 911 has to be called, instead you don't have to call 911, you can call the hospice or whoever. Like, I think it's a great idea. And I think for the nurses, I think that it should go with the kids in a folder in their backpack to school. And I think if they have nursing in their home, it should be in a folder. I don't think it should be hanging on the back of a door. I don't mean to say that. I'm not trying to be negative, but I just think that to me, that feels horrible. It feels horrible because then you have to look at, and even in a group home, then you have to look at this form on the back of the door. Like it just like every time you look at it, it reminds you of your child or your loved one or whoever possibly dying. Every time you look at it, that's what you're going to. I know we talked about having it in the freezer, and yeah, that's a good thing because it's not right there. But at the same time, having a place in a folder, having it written down where to find it, having it on digitally somewhere. I think that that's a great idea, but I don't like having it on a refrigerator, having it on a folder. I mean, not a folder, having it on the back of a bedroom door. Cause I think that like every time you look at it, your heart drops as a parent or as even a caregiver. I don't, those are just my feelings because I've had to go through it. I had a child, my Michael was not, he passed away, but he was also very, very, very medically fragile. So, I just can't remember, what's the acronym for it? The
Most.
acronym for what?
Most.
MOLST.
MOLST.
So the most, I wish that I had that for Michael. That would have been amazing to have for him because he was so medically fragile that even though, he died from the fall, he could have died from a respiratory disease. He could have from going in and have pneumonia. He could have died any which way, because myself and the nurses cared for him, but he was so compromised that he could have died years ago. And if I had it, then I think it would have been a game changer because it's not saying that, like, I can change my mind, you said. So it's not saying that, definitely don't do life-saving procedures. And I could change my mind, but if he's at school and something happens, then you go by that form. Or if he's somewhere not with me with the nurse, then you go by that form. Or if he's at the hospital and I'm not right there, then they go by that form. And I think that that's a positive thing. I don't know, as a parent, I'm just saying.
May I call you Carolyn? So Carolyn,
Yes,
thank you for the comments. And as I think this through, I don't know if we really contemplated for children that are living in the home where the form should be. We think
Right.
about, and again, no one likes to think, and again, I'm so sorry for your loss. No one likes to think about
Right,
young
no, I
people
understand.
at the end stage of their life. But your comments are so critical and so important, because when we talk about the door or we talk about the refrigerator, we're talking about adults in structured settings. So
Oh, I understand that, yes.
this is going to give us some fodder, some conversation to include as we
Right.
move forward. And here's where I think we probably, when we do our training, particularly we have a whole slide for pediatrics. This is where we should
Right.
probably have conversations about in situations like these. This is probably the
Right.
best place to keep the form. So thank you. That's very helpful.
I'd like to
I'm
validate.
just talking, I'm not talking about adults. I'm talking about children
Right.
because, like, for a
Absolutely.
parent, it guts you to go to see that form on a door or on a refrigerator. I'd be like, no, 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 no. Because I had to have the form at the end for Michael when he was in hospice. I had to fill out forms, and what we did was I had the form in the nursing. I had it in a binder so everyone knew where it was in the binder. Everyone in my family knew, the nurses knew where it was in the binder, but I didn't have it out because having it out just gutted me. It just made me feel like I didn't want him to die, you know? I mean, he needed to because his quality of life, you know, he couldn't really have had a life at that point. But at the same time, it's like you can't look at it because when you look at it, it sends you into like a deep depression as a parent of a child. I'm not talking about a grown up. I'm as a child. So
Right.
that's it. I'm sorry.
Important
I just had
comments.
to say that.
I appreciate it, and we will bring it back to the group and have that discussion. So thank you. I appreciate
Okay.
it, Carolyn.
Yeah, thank you.
Okay, you're welcome. Thank you.
Thank you, Carolyn. Any
You're
other
welcome.
questions?
I just want to echo that sentiment because we've had that feedback for many, many years around the bracelets. That when we used DNR bracelets and we would put them on before a patient left the hospital, the feedback from parents and families was that those absolutely intolerable, and that's some of why there was a
Yeah.
transition to the paperwork. And we actually do counsel families to try to have a binder that has all the relevant medical information, you know, for their child, easily accessible in the home, that can be presented when necessary. So that sentiment is not lost on that has been the feedback across many, many years about these kinds of things. So thank you for sharing your experience.
And usually,
Thank
Dr.
you.
Massaro,
Thank you
the
for listening.
bracelets